Welcome to AETCM, the Emergency Medicine Show.
Yes.
It's an 18-year-old boy with no comorbs, alleged history of penetrating injury with a stick while playing with non-people around 12:30 a.m. in morning, after which he is also having associated left nose bleeding was there. Initial 10 seconds assessment.
When did the patient arrive to the ER?
Arrive at around 6 o'clock in evening.
6 o'clock. Incident happened at 12:30
p.m. 12:30 p.m. in the
afternoon.
6 hours after he went to outside hospital and then came back to our ES. Initial 10-second assessment. Airway patent with no gargling of secretions, stridor pooling of saliva. Breathing, respiratory rate of 18 per minute with a saturation of 98%. Bilateral air entry present. Circulation, heart rate is 100 per minute with a BP of 130/70. All peripheral pulses palpable. Disability, GCS is 15/15 with a GRBS of 180 per minute. Exposure temperature is February. History, 18-year-old boy with no significant past medical or surgical history came to our ER with an alleged history of trauma to his left eye. Patient was apparently playing with non-people. At that time, he got accidentally hit with a wooden stick, and a piece of wooden stick got penetrated through the lateral aspect of his eye on the lower margin of eyelid. And got impacted in the left eye. Left eye. Only entry wound is there, exit wound was not there. So they did a CT outside showing a.
What was done immediately then?
Immediately.
While playing it, suddenly
went
inside. So immediately.
They took the boy to a nearby hospital. They assessed the patient vitally and given him. They took a CT in the outside hospital.
Analgesics and all given
from outside. TT was given, analgesic was given with antibiotic of ceftriaxone, Taxim, gentamicin and metrogel was given. They took a
tablet.
No, injection. Injection, Taxim, gentamicin, metrogel. Given from outside, and then they took a CT which showing a left intraorbital foreign body which impacted into the ethmoidal sinus. So they came to AIMS for further management of that impacted foreign body. So when he came to us, we provide him with a pain score was 7/10. So we given analgesic tramadol with MSID we given, along with we given ophthal and ENT consultation. Since the patient, the foreign body was impacted in the ethmoid sinus with no global involvement. I mean eye globe involvement. ENT admitted the patient and took an MRI brain with contrast, which shows a foreign body indenting the left globe anteroinferiorly, but the globe was intact with a diffuse left preseptal edema with a bulky and edematous left inferior rectus muscle, but the muscle was also intact. Effacement of CSF space along the left optic nerve was seen with no vitreous hemorrhage or abnormal intrasubstance. Normal intrasubstance. The globe was intact, but the foreign body was impacted into the ethmoidal sinus. So basically, patient came here for further management. So ENT did an endoscopic assistant surgery along with ophthal. And removed the foreign body through endoscopically, and ophthal did an anterior orbitotomy and cleaned the wound. Since the wound was all under the coverage of triple antibiotics. Patient was started on antibiotics and other supporting measures and treated conservatively. So for this patient, when patient came,
so as an emergency physician, what are we supposed to do if suppose similar case had come to us as a primary case?
So
immediately
pain management. First thing is we shouldn't remove the impacted foreign body from our eye. and give immediate pain management. And if it is a small impacted foreign body, we can thoroughly wash the eye and try to remove it. I mean, not remove it, not pluck it, by washing whether it is moving away or not, we can see. By simply washing with saline or ringer lactate, if it is a small, and if it is removing it on its own.
But this one is a really big one.
Really
right?
big
The
wooden
big one
impacted
pierced
it.
like that.
Yes.
Okay, a stick.
Stick.
So this you can't actually do any much of a manipulation
Manipulating.
from our side,
And local
because it can
examination.
worsen the thing. Suppose if it is just a
Small
for
foreign body.
foreign body or anything, you could have done easily given an irrigation.
Irrigation, it
With
would
what?
have removed. But this foreign body in local examination was impacted deep, like penetrated through the lower margin of left orbit, and left eye was not able to open. But periorbital edema was also there. With left eye chemosis was there. But
you weren't able to open also.
open also. I was
Detailed
fully
examination
edematous.
is not possible in this. Okay, so immediately ophthal referral is the only option left to us, apart from giving analgesics as well as tetanus injection, which is already given
from outside. Antibiotic could be given from outside. Then
antibiotic
antibiotic pain management.
that was given from there.
From our side, we given him antibiotic.
So as per the new ATLS 11th edition, what antibiotic is?
Levofloxacin is newer generation levofloxacins like metromycin and
Moxifloxacin,
gatifloxacin.
IV injections as per the new.
Levofloxacin are more preferred
Levofloxacin.
because of more penetration into the vitreous
Yes.
cavity.
So that is a recommended antibiotic.
If it is not available, we can give broad spectrum gram negative and gram positive coverage can be given.
Okay, antibiotics with both broad spectrum gram positive and negative coverage you can do.
And first thing we have to do is not try to remove it if it is a big penetrating wound, and cover the affected eye with a rigid shield. Never use.
That is how we transport. Well, transport, there is something called as a metallic
rigid shield.
eye shield is there. Then you can just apply it over that and then tie a tape.
And never to apply any gauze or any direct
never apply
pressure.
direct pressure shouldn't be there. It should be like that. Or else if it is not available, you can take a cup,
Take plastic cup
or something. Keep it like that,
and then cover it with
cover
the
it,
gauze.
bandage it to the eye and then transport.
This is to direct pressure can force the content to come out, and if it is any content is already come out, can attach to the gauze, and when we remove the gauze, it can get removed out of the eye. And then antibiotics we can give, and tetanus injection we have to give. We have to ask the patient to minimize the eye movement, because extraocular movement can also cause expulsion of the intraocular contents. Then head end elevation is very important. Head end to a 30 degree we have to give. If the patient is a multi-trauma patient with the spine, we have to stabilize. We can use reverse Trendelenburg position. Then we have to treat the pain, nausea and vomiting.
What about that irrigation part? If at all it was a small foreign
if
body.
it is small foreign body, we can irrigate the eye with ringer lactate or normal saline continuously for a period of 30 to 1 hour. We can either use a Morgan's lens, which
that
is
one thing, Morgan's lens. You can just Google and find it out. The Morgan lens, you can just directly apply it on the inside the eye, over the cornea, and then continuously with 1 liter. The other tip will be connected to the drip.
saline.
And 1 liter, more than 1 liter, you can keep irrigating, so that it goes out through the temporal aspect, not here inside. So you keep both eyes. You can keep, if at all both eyes are involved, especially in chemical burns, acid or alkali burns. If it is there, you can continuously 1 liter of irrigation.
Okay.
And after some time, after doing that, you need to check the pH. And pH should be normal. That is the end point of stopping this irrigation using Morgan's lens.
In case of chemical injuries, pH should be normal. That will be the end point to stop the irrigation. If Morgan's lens is not available, we can use an IV tubing if only one eye is involved, or you can use a nasal cannula if 2 eyes are involved.
Yeah, with nasal cannula also we can just connect and pour with normal saline or ringer lactate. You can use. If at all that foreign body is lodged inside the canthus, it is too deep inside, you can actually use a syringe, and then with forceful pressure you can try to remove it, because it is too deep inside. It's unable, with the normal Morgan's lens, you're unable to take it out. You use a syringe.
In case of eye, there are 3 vital
In this
signs.
case, but you shouldn't be manipulating too much, because it's a large foreign body impacted, which has gone behind the globe
into the ethmoidal sinus. So in case of eye, there are 3 vital signs we have to take care of. One is vision, next is intraocular pressure, and next is pupil. In case of vision, first we can either ask to read a paper, read like vision card, Snellen's chart we can use, or at least light perception we have to check in case of vision, if vision is intact or not. Next, intraocular pressure, we can use an handheld tonometry, but we should
you can't
avoid it
use these things in this case.
impenetrated patient.
If it is a normal normal foreign body, small foreign body, you can do all these things. In this particular case, you're not supposed to do all these things.
Anything. If any pressure, excess pressure we are going, there's a chance of expulsion of eye content, which is more dangerous for the patient. Then assess the ocular area or periorbital area if any other injury is there. Then in case of for this patient, like only analgesia, antibiotic and TT.
What if there is like if you see the patient has got a protruding eye, like restricted eye movements and severe pain, decreased vision, what should you suspect? What is the emergency in case of eye trauma?
We should suspect compartment syndrome.
Yeah, orbital compartment syndrome is one thing you should suspect. Then what is the treatment of choice?
Lateral canthotomy or cantholysis we have to done within 90 minutes to preserve vision. If it is more time complete, the vision damage will be more severe. Cantholysis is basically we have to cut the lateral aspect of canthus after giving local anesthesia, which is the orbital emergency we don't usually see in our ER, but it's
that is one thing to be borne in mind. Orbital compartment syndrome, very often they ask for FRCM-SBA examination.
It's more common after a trauma, facial trauma. It is basically orbital, in retroorbital or orbital hemorrhage, which causes compartment syndrome, since there's a Tinen's capsule, in that capsule around our orbit.
And you're just relieving the pressure by doing the canthotomy. Okay.
So then basically there's in our new ACLS 11th edition, there is a chart called Ocular Trauma Assessment prioritized by the time, which include diagnosis, like the first 3 diagnoses, that is chemical injury, compartment syndrome and open globe, should be diagnosed individually, and the next 3, that is blunt trauma causing hyphema or orbital fracture and eyelid, we can diagnose simultaneously, which is one of the new addition in AETCM. Then as we these are the 6 eye related emergencies we usually come to ERs. First is chemical injury. The first thing we have to look for is what kind of chemical it is, alkali or acid. Alkali is more dangerous to eye than acid. The only thing is we have to do is thorough copious irrigation, either using Morgan's lens or IV tubings, more than 1 liter we have to give till the pH is neutralized, and then call ophthalmologist ASAP. Second is compartment syndrome, most commonly after facial trauma or a multi-trauma. Eye will be swollen, bruised or firm feeling eyelid will be there with a protruding eye and firm on palpation. There is significant blood under the conjunctiva will be there, with poor eye movement and restricted pain while moving, limitation of movement with poor vision. Treatment is canthotomy or cantholysis. We have to done within 90 minutes to preserve vision. The third one is open globe, which is either distorted pupils will be there, or a foreign body protruded in or protruding out of the orbit with pigment or intraocular contents outside of the orbit. we have to give a rigid shield or cup over the eye without pressurizing the eye, and add IV antibiotic tetanus and transfer the patient to immediate ophthalmology care. The next is a blunt trauma to eye. Globe will be intact or blood between the cornea or iris. Treatment is pain management, manage pain, nausea and vomiting, and ophthalmology consultation. Orbital fracture is also, we have to look for any compartment, we have to rule out compartment syndrome, and look for double vision or restricted eye movement, which is also definitive is always ophthalmology consultation. In case of eyelid laceration, abnormal eye position or skin breaking is there within the inner 1/3 of eyelid near to the nose. We have to keep the eyelid moist with a wet gauze and antibiotic ointment. Then refer to a definitive care is always with the ophthalmologist. Then always treat the underlying, like it's always life, limb, and then eye. Treat the emergency condition, then look for any limb disability, then look for eye to give definitive management.
Other tests are also there to assess corneal injuries, but it's not relevant in this particular case. Like Cyril's test and all are there.
Cyril's test to look for any vitreous hemorrhage, vitreous leak is there. In case of penetrating injury, after we remove that foreign body, we can do Cyril's test, which is basically we will a fluorescent strip will be attached to our eye, which will have a dark orange color. If there is a leak, there will be light color will be there. We can look for any
that's using a different this thing lens is
light.
Cobalt light filter is there. With that only you will get all these things. But in this particular case, it's not.
Only analgesic, IV antibiotics, and pain management.
And the CT, what did it show?
CT showing a foreign body without that goes below the antro inferiorly to the ethmoid sinus, not touching the globe.
Okay.
And then globe is intact.
So probably his vision will be spared. Like,
Hopefully.
Okay. Anything more to be added? Anything more? Okay. Thank you.
Thank you.